Dr. Sanjay Yadav. I request all the speakers to finish in time because we have got time constraint, and after this session we have got very important orations lined up. So please finish in time. Dr. Sanjay Yadav.
कार्तिक कार्तिक कितने मिनट तक होता है? सर
5 plus 2 5
5 plus 2 है
ग्रेस 5
Good morning, respected Chairman sir, my teachers, professors and colleagues. To start with the free paper session, this is a very small case focusing on a very specific point, on a common fracture which we encounter as a resident, and it is one of the few initial cases which we get to do. It's about an irreducible variant of intertrochanteric fracture which we encountered while operating. Usually acceptable close reduction is possible for most of the simple intertrochanteric fractures. We encountered an irreducible variant where the shaft fragment included the lesser trochanter and there is a long spike on the proximal head and neck fragment. We report our encounter with such a case in which the proximal fragment was lying in extension and it was sunken medial to the shaft fragment. A 30-year-old male presented to the emergency with a high velocity motor vehicle accident. He had trochanteric tenderness on the right side, and in palpation we can feel a swelling in front of the hip. The radiographs revealed a trochanteric fracture with the lesser trochanter attached to the shaft fragment. A CT scan was obtained to better delineate the fracture. It showed the typical pattern with an overridden shaft fragment and long spike on the head and neck fragment, as you can see on this X-ray. Where is the pointer? Pointer component. Where you can see this fragment, and in this lateral view on table, it's a long spike in the proximal fragment. It is lying to lever out the sunken femoral neck. However, it was unsuccessful. At that time, we introduced the shams pin in the neck, and then we levered out the proximal fragment into reduction. And then definitive fixation was done with a dynamic hip screw. The patient was operated using a fracture table, and the reduction steps I already described. The operating management of this case is discussed in detail and is compared with the one described previously by said et al. These are the post-operative, immediate post-operative images. These are the follow-up radiographs. Coming on to discussion, intertrochanteric fracture usually they occur along a line between two trochanters, and the reduction is usually achieved by standard maneuver of traction, abduction, internal rotation. Commonly, there is a posterior sagging of the distal fragment, which can be corrected by applying pressure from below. But certain fracture patterns need more attention and suggest need for open reduction as described. In this relatively uncommon fracture pattern, the proximal fragment was extended and was sunken medial to the shaft fragment. The reduction of the proximal fragment was made worse by the interposed iliopsoas tendon. And said et al. In 2005 reported such a variant and proposed a 3-step technique. They did not use the fracture table. They flexed the hip into a figure of 4 position to relax the iliopsoas and then tried to lever out the proximal fragment. And according to them, reduction would be difficult or impossible on a fracture table. But as we are all used to operate it on a fracture table, so we use fracture table for that. So the iliopsoas tendon remains attached to the lesser trochanter, and the long spike on the head and neck fragment often gets caught between the iliopsoas and lesser trochanter. And the iliopsoas muscle pulls the shaft upward in front of the capsule of the hip joint. Clinically, the overriding upper shaft produces swelling if the patient is not very fat, and radiologically also you can appreciate the proximal riding. The carry-home message is, anticipating this difficulty from the clinical and radiological picture will enable the surgeon to plan for open reduction And this variant of intertrochanteric fracture occurs in a relatively younger age group of patients with stronger bone due to a high energy trauma. Thank you.
Thank you, Dr. Yadav. Any questions on this subject? Okay, thank you, Dr. Yadav. Next.
Oh,
Dr. Goyal.
Sir.
Dr. Yadav,
sir.
do you routinely go for a CT scan in trochanteric fractures?
No, we routinely do not do when we suspect that there is a coronal segment or there may be comminution, then we do. Otherwise, we have another study going on. So for that, we have done CT scan for a few cases.
In this case, when you had a preoperative X-rays, what led you to go for a CT scan? The things were so clear-cut in AP and lateral view, particularly in the lateral view. What more information you collected with the CT scan?
I mean, usually we don't do...
In this case, what more informations you received from CT scan which you were not able to receive by a plain radiograph?
No, actually the CT scan was done as a part of a different study where we are studying the anatomy of a proximal femur. Otherwise, it's not a routine.
I will call
Thank you.
Anantha Krishnan, the next speaker.
Good morning to all. This presentation is from Sri Satyasai Institute of Biomedical Sciences, Puttaparthi, and myself being Dr. Anand Krishnan. The title being Proximal Femoral Fractures, a Systematic Analysis of 800 Patients. Going to the introduction, proximal femoral fractures are the most commonest fracture patterns which we encounter in our routine practice, and it's more than 50% of the hip fractures which occur. And the issues which we faced are the pattern of injury, which doesn't fit into any of the international classification systems, and the fixation strategies which we adopted for that. The proximal femoral fractures which we include are the post-traumatic basilarticular fracture neck of femur, intertrochanteric fracture, and the fracture which is intertrochanteric to subtrochanteric extension. We had two things in our hand. One was the limiting factor, another was the guiding factor. Limiting factor being the fracture pattern and the fracture combination, which was very unique to our set of people, and the bone quality, which is severely osteoporotic, and we are in a zone of endemic fluorosis. And the guiding factors being the reduction methods and the fixation strategies. That is, we use only 4 strategies: DHS, DCS, recon, and the proximal femoral locking plate. These are the existing classification which we already know: Boardman, Griffins, Evans, AO, Kiles, and Ramadius. And the methods and materials which we use, it's a 4-year study from 2008 to 2012, and it involves 800 patients, and these patients were selected based on 2 things. They should have a highly unstable intertrochanteric comminuted fractures, and second thing is they should have a minimum follow-up of 6 months to 1 year. So it's average age of 65 years, and male to female ratio is 2:1. The classification which we use is a pillar mode classification. It starts with superior, inferior, medial, and lateral, as described in the diagram. Superior consists of basilarticular fracture neck of femur, intertrochanteric fracture. The lateral being the greater trochanteric fractures, and the middle being the posterior complex and the lesser trochanter, and the inferior being the high subtrochanteric. The high subtrochanteric being the point from the tip of the lesser trochanter to the feelings in between the feelings type 1. These are the results which we had. Superior middle pillar, this is 3 months post-op, this is 6 months post-op. All pillars fracture pattern, 3 months immediate post-op, and this is 6 months post-op. Inferior middle pattern, this is treated with proximal femoral plate, this is 6 months post-op. And this is all pillars treated with recon nail, and this is 6 months post-op. And all pillars treated with, again, DCS. And of course, we had failures also. The failures, this is immediate post-op of DHS, and within 3 months, the screw had backed out. And this is another fracture pattern, which we had fixed in valgus position with DHS, and this is 3 months. So conclusions, yes. All the fractures taken here are the committed unstable injuries, and the fractures occurred in flexion mode because our patients usually walk with the 5 degrees of hip flexion and 5 to 10 degrees of knee flexion with 5 degrees of more than external rotation, which is accepted. And so all these fractures we aimed at the anatomic direction, stable fixation, and plus or minus bone grafting. So when there is involvement of two or more pillars, we consider that as an unstable fracture pattern, and we always place the screw in the inferior portion where we have the maximum bone strength. So out of 800 cases, we had 679 DHS, then 91 DCS, and then 21 recon and 9 proximal femoral blade. Based on the pillars, the maximum being the superior and middle pillar, that is 253 fractures we encountered. The next being the all three fill pillars, that is 149, and the next being the all pillars, that is 106. And bone grafting was done in 131 cases. Yes, we had failures, 71 failures we had, and those failures were in the initial 3 months of time, and the maximum being for DHS, where we converted 14 cases into DCS, and 7 of them went into another failure. We converted them to cemented bipolar and 1 into THS. And 13 were cemented, 13 cemented bipolars were converted from DHS, and there were 7 which was done by modified Diamond-Houston method, and 6 were by DHS, and 14 had no reports, and 4 people we just left alone. And the other failures were DCS were 9 and recon were 3, and the proximal femoral blade out of 9 there were 1 case. So yes, based on all these things, we had conclude a classification system for the better outcome of the surgical management. When there is a superior and inferior pillar involvement, you do an anatomical reduction and stable fixation plus or minus bone graft. The modes of fixation we suggest are the DHS, DCS, and the proximal femoral blade. And when there is involvement of the medial pillar, invariably in case of medial pillar and 3 pillar involvement or the 4 pillar involvement, you go for bone grafting for sure. And when there is inferior pillar involvement, then you go for recon nail. Otherwise, the mode of fixation is like DHS, DCS, recon, and proximal femoral blade. Thank you.
Any questions?
What do you think that the DCS is better, less complications than the PFN?
No, we had maximum success with DHS. So we had maximum success with DHS, and it all depends on these. Initially we do a close reduction. It all depends on what angle you get. Suppose if it's going to be less than 120 or 110, then we prefer DCS than the DHS.
Thank you.
Thank you,
So
sir.
now I will call next speaker, Ankur Gupta.
ऑफ कर दिया किसको?
Good morning, everyone. I am presenting intertrochanteric fractures treated with the new PFNA2 or proximal femoral anti-rotation nail in the Indian elderly patients. In 2004, AO introduced a new system called the PFNA. But because due to the Asian population in 2008, a modified PFNA2 was introduced. The major development is the helical blade, which is supposed to compress the surrounding cancellous bone. To our knowledge, there are few studies on the PFNA available in the Indian population, so that was the purpose of the study. 28 consecutive intertrochanteric fractures were treated with the PFNA extra small nail. 4 patients were excluded because they were less than 60-year-old. So the total 24 patients were available for the outcome and analysis of the study. All fractures were treated with closed reduction under C-arm. Entry point was a GT tip. And after the PFNA was inserted, a 3.2 mm derotation wire was put. The blade was introduced over a hammer. This is the helical blade, which is different from the screw which we used to put. Once the the blade is mounted, the blade opens up, as you can see here. And once it is finally tightened, the screw is loose. So then it is hammered, it rotates. Evaluation was done using the method of Cleveland and Bosworth, in which there are 9 zones, and according to the zones, the position of the blade is decided according to the zones. The operative time and the blood loss was noted, TAD was noted, and hip Harris score was done. All patients were mobilized as soon as possible with full weight bearing. The results, the average age of the patient was 75-year-old. Type A2 was seen in 12 patients, A1 in 10, and A3 in 2. All cases were done using minimal invasive incision, entry point ranging from 2 to 4 centimeter. Result, the mean duration of surgery, skin to skin, was 23 minutes. The mean hospital stay was
5 days. In all 24 patients, the fractures united. At the final follow-up, there was excellent and good result in 83.3 patients. These are some examples. This is a type A1 fracture treated with the PFNA, the union. This is an A2 fracture, again treated with the PFNA. And at the union, this is a A3 fracture with the lateral cortex, again treated, and the union. Complications. Burner in 2008 reported a high post-operative perforation rate of the helical blade, which we also noted in one of our cases. This is the case in which the helical blade perforated, unlike a screw which cuts out. This is a new complication which was seen in PFNA2. This blade actually perforated inside without cutting out the head. Other complication, like I've said, the screw cutting out the head, which this was not seen in any of our complications. Sain et al. Reported iatrogenic fractures during the PFNA2, but we did not encounter any such complication. Complications of lateral sliding of the helical blade were also reported in 2008, but we did not see any of such complications. Now coming to the discussion, the main difference from other nail is the single proximal helical blade. The use of a single screw prevents the Z effect. The wide surface area and special design of the blade enables the insertion and impaction even in the osteoporotic bones. No bone is removed during insertion as the blade compresses the surrounding cancellous bone. PFNA has a lower degree of invasiveness because of its advanced instrumentation, leading to less blood loss and reduced operative time. And it has been demonstrated that the helical blade provides stronger fixation and rotation control over the femoral head. Take-home message: the newly developed PFNA2 is an effective intramedullary device. It can be safely used in elderly Indian patients. The complication of helical blade penetration in the hip is to be recognized and would need further evaluation. But as our study size was small, there were several limitations to our studies. Further randomized trial comparing the PFNA with other devices is needed. Thank you.
Any questions?
Ankur,
Sir.
you said you measured a tip apex distance in all cases.
Right.
Can you tell me what was your average tip apex distance?
Sir, my average tip apex distance was more than 20, around 25 to 28. The reason being, after first few cases, I read the article of the helical blade penetration, in which it was recommended by Burner et al. That one can keep a tip apex, one should try to keep a tip apex distance a little bit higher.
You mean to say in using PFNA2,
Yeah.
we should be keeping the tip apex distance a little higher than what is actually recommended?
Yeah, because this is not a screw. This does not go and get hold in the subchondral bone. This is a blade. It actually compresses the bone all over the neck and all over the head. So it was recommended in a study in 2008 that because of this new complication, which was not seen in the DHS before, of blade penetrating into the head, this recommendation was done, which I followed.
Right. Thank you.
Sir.
Ankur, I have a question for you here, this side.
Sir.
You said that there is a complication which is reported in literature also that it penetrates inside.
Sir.
Probably I think that is because of failure of sliding rather than anything else. And there is some flaw in the implant itself which prevents it from sliding out,
Sir.
which should be the normal course.
Exactly.
And that is why it goes inside.
Exactly.
So the implant should be improved rather than improving or increasing the TAD, because that will cause failure rate because of cutout.
You are very right, sir. So that is why in my conclusion, I said we need more studies to prove whether it is the implant, it is the technique, or this implant works with a higher TAD also giving a good result. So I am not sure what is the...
Thank you, Dr. Gupta. Thank you.
Thank you, sir.
Next speaker is Dr. Moghli Kasi.
Good morning, Varanda. I am Dr. Kasi Vishwanath from RMC, Kakinada, Andhra Pradesh. I am going to present a paper on primary cemented bipolar hemiarthroplasty in unstable and retrocondylic fractures in elderly. So intertrochanteric fractures in elderly is characterized by severe displacement and comminution. So classification, there are so many classifications, but recently AO classification is most commonly used. So A1 is stable, A2 is unstable, and A3 is unstable with plate-device fixations. So why not osteogenesis is preferred in elderly patients? Because stable intertrochanteric fractures can easily treated with osteogenesis with good results, whereas unstable intertrochanteric fractures is challenging because of poor bone quality and osteoporosis and other underlying diseases. Why osteogenesis is difficult in elderly? Because of excessive collapse, loss of fixation and cutout of the lag screw and delayed weight bearing. Why bipolar is used in elderly? Because to allow an early post-operative weight bearing and rapid rehabilitation. So the aim and objectives of my study were to evaluate the functional and clinical outcomes of cemented bipolar hemiarthroplasty as a primary treatment for unstable intertrochanteric fractures in elderly. So it's a prospective study of 20 patients with 11 males and 9 females. The study is conducted from 2010 October to 2013 September, and 12 cases of 2.2 and 8 cases are 2.3. The inclusion criteria were unstable intertrochanteric fractures, age 65 or older, and osteoporosis. The exclusion criteria were patients who are less than 65 years of age and stable intertrochanteric fractures who are non-mobile previous to injury, and the patients who are unfit for surgery. The surgical procedure is done under spinal or general anesthesia under lateral equilibrium position, anterolateral approach, that is through the fracture site, that is transtrochanteric window, the femoral head and neck are removed, and the canal was reamed. Then the trial rests were performed. This is the main crucial step to restoration of neck length, offset and version. The definitive femoral stem is cemented into the femoral canal, and the neck and GT is reconstructed with SS weights depending upon the morphology of the fracture. And the repair of abductor mechanism is done and wound closed in layers. The results, the mean duration of follow-up is 18 months with the Harris-Hip score, and the mean duration of weight bearing is 5 days, and one case has superficial infection, and one case of stem loosening, and one case has an intraoperative crack of femur while preparing the femoral canal, and 3 cases of shortening of 2 centimeters, and 2 cases of external rotation of less than 20 degrees, and 3 cases of abductor latch. There was no instance of post-operative dislocation of prosthesis, and there is no revision surgery, and 1 patient is died within the first year of follow-up. It's the results. It's with the Harris-Hip score, it's excellent in 4 cases and good in 9 cases, and fair in 3 cases and poor in 1 case. So now 70 years male with intertrochanteric fracture pre-op X-ray showing on left side. And there's 6 months follow-up. So at 18 months. And second case is 69 female with left intertrochanteric fracture femur. It's a pre-op X-ray at 2 months follow-up. Reconstruction of GT and calcar is replaced with cement here. And at 12 months follow-up. It's the final follow-up. So 66 male with right side intertrochanteric fracture femur. So at 2 months follow-up, 6 months follow-up. The limitation of my study is a small sample size and short follow-up, and the study also have too few patients for doing analysis on rare adverse effects such as infections, dislocations, periprosthetic fractures. And the discussion is complexity of intertrochanteric fractures in elderly osteoporotic patients poses a challenging problems with an added risk of increase in morbidity and mortality. And Hezens et al. And Feldin et al. And other studies showed that internal fixation of both stable and unstable intertrochanteric fractures reported a failure rate between 60 to 32%. And several studies in literature have shown that cemented bipolar hemiarthroplasty has given good constant results in terms of early ambulation and good mid-term survival rates. Even our results were synchronous to the studies in terms of early mobilization, less implant-related complication and faster overall rehabilitation. So conclusion is cemented bipolar for the unstable intertrochanteric fractures in elderly is to be considered as one of the treatment options for early mobilization, rehabilitation and less implant-related complication. Thank you.
Thank you, doctor. Any questions?
Yes, we are doing the hemiarthroplasty.
Yes.
For some time in the osteoporous bone, we put the cement into the holes of the, where we put the screws of the DHS as well as the plate. And we hold that. That holds very good, I tell you. So why the need of the so extensive arthroplasty, when we can very well say it with the cemented in the screws, the dynamic screw and the plate screw. It holds very well. And if you want, sometimes we put surrounding at the fracture surface cement all around. I've operated many cases. On the fracture side above, this is a DHS, intertrochanteric. We put the cement all around. It gives a very good result.
Okay.
Why you put the hemiarthroplasty?
Because of if you put the screws, we cannot mobilize the patients immediately post-operatively. So, because we have selected in this study, we have selected the patients above 65 years who cannot stay for a long time on the bed. We have to mobilize the patient for early rehabilitation. So, to prevent the post-operative complications like an elderly, for a prolonged mobilization, there are so many complications. That's why we have selected the bipolar hemiarthroplasty.
Number one, they can move early if you apply the cement.
Okay.
But number two, it hardly matters whether they walk for 6 weeks or they don't walk. So I don't think it's a very...
Dr. Agarwal, you have made your point, yes. Next, please.
What about cementing? Did you use cement gun, this patient?
Sir,
what about cementing has been done for this patient? Cement gun or like a free?
Just a first generation cementing, sir. We have
So because cement gun would have been better because you, as you told, it is osteoporosis capacious canal. The cement gun used, the entire canal will be cement.
Yes.
So the duration of the longevity of the process will be more. Using a first generation cementing like you, and the tip of the stem will be not filled with cement.
I don't think ambulation is a problem after cement, augmentation and DHS also.
Okay.
We have been doing this in 72, 75, even 8 years old patients. Day 1 post-op ambulation without any problem, and you don't even require cementing in the shaft area. Just cement in the head area, 4 to 5 ml only, and that takes care of it very well. So I don't think hemiarthroplasty, primary hemiarthroplasty is a good option in such cases. If you can salvage the head, that's always better.
Sir, I think I endorse your surgery in people who are elderly, who are probably not likely to survive more than 7 to 10 years. This is the ideal operation. And I feel that the results of this operation are very good the way you have described. Only thing I feel is the trochanteric wire cutout is one of the common complications. Yes. So I think the trochanteric reconstruction is one of the major issues.
Yes.
And even if the trochanteric wire cuts out, still the patient walks about and moves about. And I have also done whatever has been described about the cementing, the DHS or whatever you do it. I feel it is all right in, as you described, into the smaller grade of fractures, grade 1 and grade 2. Grade 4 with everything out in osteoporotic bone, probably this is the best option.
Thank you, sir. Thank you, doctor.
Thank you.
Next speaker, Nishit. Dr. Nishit Palo.
Respected chairperson, seniors and friends, my presentation is late presentation and delayed surgeries, factor outcome in patients with vegetative fractures. I'd like to thank Dr. Santosh Rath and Professor Biswal for guidance and support. Elderly patients with hip fractures constitute the single largest group of emergency orthopedic admissions. Hip fractures are common and serious. They cause long-term pain, disability and even deformity. More than 10% of survivors will be unable to return to their previous residence. The problem being only a small number of reports of incidents of hip fractures in Asian population. In 2050, 6.26 million hip fractures worldwide, out of which 50% will occur in Asia. In 2020, annual cost of hip fractures in US is $16 billion and worldwide $131 billion. Aims of our study was to examine trends in fragility hip fractures in Bhubaneswar, to study the causes of delay in patient's presentation and hospital and cause of delayed surgeries, to prevent these causes, to improve care of patients with fragility fractures, develop a database to assimilate and organize valuable data, and to stress for the need of national hip database for better services to elderly. It's a population-based prospective epidemiological observational study. Patients visiting outpatient department or casualty with diagnosis of fragility fractures from June 2012 to May 2013. And we take the National Hip Fracture Database UK as standard framework with BOA BGS Blue Book modified for Indian setup. Variables assessed would be age and gender distribution, fracture pattern, mode of injury, timing of presentation with cause of delay, distance travel, timing of operation with causes of delay, average hospital stay, incidence of pressure ulcers, man hours lost to work, and 30-day return to home. Inclusion criteria, male, female patient, 55 years age, more than that, hip fractures, fracture neck, intertrochanteric or subtrochanteric fractures, any etiology, fresh or old fractures, operative, conservative, or no treatment. The problem with hip fracture patients, patient-related, are delayed present to the hospital, delayed surgeries, huge kilometers traveled, and man hours lost to work, and hospital-related pressure sores, lengthy hospital stay, dependency, and nosocomial infections. Our study encountered 146 female patients and male 105 with a ratio of 1.4:1, female to male. Females were more affected in the age group 72 to 79, and males were more affected in the age group 60 to 69. Mean travel for each patient was 86.4 kilometers, and maximum from our hospital was Medinapur, that is 321 kilometers. Mechanism of injury, fall dominated with 126 patients. Most hip fractures result from a fall or stumble. Only 5% of these cases have no history of injury. We encountered 148 intertrochanteric fractures, followed by 95 fracture neck of femur, out of which 50 were subcapital that dominated. Greater than 1 day presentation were in 202 patients, mean of 18 days and standard deviation 60.9. Effects of delay presentation is pain, discomfort, fat embolism, uncontrolled blood sugar, infections like urinary tract infection, pneumonia, compound wounds, pressure sores, disused muscle wasting, and difficulty in surgery, with sometimes delayed or non-human if the patient presents very late. Causes of delay in presentation were flourishing and misguiding quack practice, that was the most common cause, ignorance by the family towards the injury, unawareness about the government medical schemes and benefits, lack of specialized and definitive medical care at the root level, patients attenders were unavailable sometimes to bring the patient, arrangement of funds for treatment they were arranging, lack of affection towards elderly, and auspicious date and festivities delayed the presentation to the hospital. We operated 166 patients and conservatively managed 65 with a ratio of 2.5:1, operative to conservative. The optimal treatment for these injuries is surgery. Timing of surgery from the patient's presentation to hospital was in 86 patients more than 2 days. That is constituted 51.8% with mean of 3.5 days and standard deviation 2.8. Surgery for hip fractures should be performed within 24 hours of injury. We operated only 2 patients on the same day of injury out of 251 patients. Common effects of delayed surgery are increased man hours lost, the treatment cost increases, lengthy hospital stay, persistently altered biochemical environment of the body, increased infections, depressions, pain, and pressure sores. The common causes of delay in surgeries were attenders were negligent, they were trying to arrange funds, that was the most common cause. Patient awaiting place on the operation list, public holidays, unfit patient, administrative issues, patient attenders were unable for consent, unavailability of implants were some causes. 148 intertrochanteric fractures, proximal femoral nailing was preferred. In neck of femur, hemiarthroplasty in 56 patients, that was preferred. Subtrochanteric, 8 patients, all operated with long proximal femoral nail. Incidence of pressure ulcers, relative risk 2.3, patient admitted, 21.6% developed pressure sore, not admitted 66.6%. Some common variables that were assessed, but out of these, mean is man hours lost, 157.85 hours per attender, that is equivalent to 19.7 days of work per attender. Distance travel, mean 86.4 kilometers per patient. Hospital stay, mean 13.5 days, maximum of 30 days, and minimum 8 days. 30-day return of home is 92.4% patients. Fall assessment, good, 92%. Bone protection advice was given to 100% patients. Weight bearing at time of discharge, 51.2% patients. Medical complications in admitted patients were seen in 36.5%, that is 68 patients, but it was more in the cases in which the surgeries were delayed. Discussion. Fragility fractures are common, disabling injury of elderly, which makes them dependent on family even for basic needs. In our study, estimated losses according to the man hours lost goes up to ₹10 lakhs. Early presentation and operations relate to better prognosis and rehabilitation, facilitates early return to work and freedom from dependency. Our study concludes that patients present late to the hospital, but our surgeries are delayed too, thus increasing the man hours lost to work, incidence of pressure ulcers, nosocomial infections, hospital stay, and ultimately the treatment cost. All this can be prevented by careful planning and early intervention. This study is a golden initiation, eye-opener study, motivation for improved care of elderly who deserve the topmost standards of care and affection. With the hope to assimilate and organize valuable data on national basis to lay tracks for National Facility Hip Fracture Database, this study was initiated. These are the references. We all have these cases. Registering data does not take much time. So let's start today. Thank you.
Any questions?
Thank you, sir.
Next speaker is Harshad Javalkar.
Good morning, everybody. I am Dr. Harshad Javalkar from Hyderabad, and I'm going to talk about the short-term results of proximal femur locking compression plate for intertrochanteric fractures of the hip. As we all know, intertrochanteric fractures can be quite challenging because of osteoporosis, which is associated with poor implant purchase, the high load-bearing requirements in the region, and the variability of the fracture pattern, which has implications on the selection of implants. As we all know, locking plates in other regions of osteoporosis have shown good results, like the Philos plate of the proximal humerus. For this purpose, the same concept was applied to the proximal femur by the AO group in 2007 when they launched locking plates for the improved fixation in osteoporotic bones around the trochanteric region. The locking compression plate is an anatomically contoured plate which has 3 holes in the proximal region which can accommodate locking screws. The locking screws converge within the femoral head and neck to form a triangular construct. For these two reasons, the locking plate and the triangular construct, it is promising to have better results in osteoporotic bone. The purpose of our study was to evaluate the functional and radiological results of the PF-LCP for intertrochanteric fractures. So for a time period of 2.5 years, from January 2011 to July 2013, we operated on 23 patients with intertrochanteric fractures. The average age of the patient was 65.7 years, and according to the Evans classification, 15 were stable and 8 were unstable types. We used Indian make implants for the study. A brief mention about the surgical technique. The patient is positioned supine on a fracture table with the affected limb in traction attachment. C-arm is used to reduce the fracture preoperatively. A direct lateral approach to the hip is used. Then with the help of sleeves, guide wires are inserted into the proximal part of the femoral head and neck, which is confirmed under C-arm. Subsequently, screws are used to fix the plate both proximally and to the shaft. On the bottom hand right corner is an example of the post-operative X-ray. Coming to the results, the average duration of follow-up was 1 year and 4 months, ranging from 6 months to 27 months. We used both radiological and clinical parameters to assess the results. The Harris hip score was used functional grading. So out of 23 patients, 5 patients had an excellent result, 8 patients had a good, 3 fair, and 7 patients had a poor results. The average score was 72.8, which falls in the fair criteria, ranging from 17 to 98. Radiologically, we had a good outcome in 10 out of 23 patients. By good outcome, we mean that the fracture has united completely, without any varus collapse, and no implant-related problems like loosening, breakage, or cutout. Out of these 10 patients, 8 were stable and 2 were unstable. Radiological failures were seen in 13 patients out of 23, and some had more than 1 complications. We observed 3 non-unions, 10 secondary varus collapses, 5 each of loosening and breakage of screws, and 1 cut through from the proximal fragment. These are some case examples. This is one patient, 65-year-old lady, who did very well. The fracture has united without any problems, and she has an excellent Harris hip score of 91. Another patient, 69-year-old lady, with slight varus collapse on the X-ray, but a good Harris hip score, functionally doing very well. The third patient was not so lucky. Radiologically, you can observe by 6 months there is one screw breakage, and by 1 year follow-up, the fracture line is still visible. Second screw has broken, the third one has backed out. But surprisingly, clinically the patient is doing quite all right. Even though the X-ray looks bad, he has a Harris Hip score of 74, which falls in the fair category. This patient was really unfortunate. In spite of having a well-reduced X-ray on the immediate post-op and good fixation, at 6 months follow-up, we can see that the fracture has collapsed into varus. There is loosening. 2 of the screws have broken. And he has a Harris Hip score of 47, which is very poor. Coming to the literature, even though biomechanically the plates have been proved to have been very efficient, but when it comes to clinical studies, the literature is quite conflicting. There are studies in favor of this plate which quote good early outcome, a feasible alternative, good to excellent healing with stable fixation and high union rates. But literature against the plates is also quite strong. There are a number of studies which say that it has a high rate of failure even when surgery is performed by experienced and fellowship trained traumatologists. Major complications in 7 of 19 patients, a higher risk of construct failure and even catastrophic failure. Discussion, both literature and our experience, we can say that failures can be due to 3 factors. Technical factors, leaving the plate proud, which can increase the lever arm, cross-threading of the screws, which do not permit locking of the screws within the plate, and malpositioning of the screws within the head and neck can contribute. Patient factors like non-compliance with weight-bearing instructions and physiotherapy also play a part. And last but not least, implant design can also play a part. It is basically an extramedullary